Welcome, Dr. Stephan Ramos. His title of the talk is Hematopoietic Stem Cell Transplantation Promotes Islet Transplant Tolerance and Diabetes Reversal. And we're very happy to have him here to discuss this work. A little bit about him. He's a postdoctoral fellow with Dr. Sung Kim at Stanford University, where he studies immune tolerance and beta cell regeneration in type 1 diabetes. He earned his PhD from the University of Colorado, training under Holder Rush at the Barbara Davis Center for Diabetes, and his research focuses on reversing diabetes by establishing immune tolerance through mixed hematopoietic chimerism and thymic education. Living with T1D, he brings both personal perspective and scientific passion to his work. You can feel free to drop questions in the chat, and we also have a link to the paper there. And welcome, Stefan. This is really an exciting time. We had a little chat prior to the talk, and it sounds like more papers are coming from this first paper and inquiry, and it's really exciting times. I'm very happy to hear about this work. So take it away.
Great. Thank you, Monica. So as Monica mentioned, Stephan Ramos, a postdoc at Stanford with Dr. Sung Kim. And thank you all for coming out this morning, afternoon, and excited to tell you about my work. So using hematopoietic stem cell transplantation to try and promote islet tolerance and diabetes reversal. And so islet cell replacement is a promising and FDA-approved solution to type 1 diabetes. And so with this approach, we can take a pancreas, isolate the islets, and transplant them into a diabetic individual. And so we can collect these islets from an autologous source, meaning it's coming from the individual themselves. And so in this case, you're going to have immune compatibility and acceptance of these transplanted islets. Alternatively, you can acquire these islets from an allogeneic source or a non-matched donor. In most cases, this comes from a cadaveric donor, where we can then take a cadaveric pancreas, isolate the islets, and transplant them into the diabetic individual. This is all great and good. However, we now introduce the concept of immune incompatibility. And so if left alone, the individual receiving these islets will then reject these non-self islets. And so these individuals have to then undergo chronic immunosuppression in order to retain these transplanted islets. However, this also has downsides, including increased risk for malignancy, infection, and beta cell toxicity from these chronic immunosuppressive drugs. And so in order to make this approach more widely available, we have to overcome certain barriers, including the need to achieve immune tolerance to allogeneic donor islets without chronic immunosuppression, the need to prevent repeat autoimmune attack in the case of type 1 diabetes, and also the shortage of donor islets. And so in this talk, I'm going to primarily touch on number one. We do have a bioarchives paper out that it's currently in revision, where we discuss approaches to kind of attack the second barrier, and I will briefly talk on the third barrier as our future work. And so mixed hematopoietic chimerism is a strategy that has been used to promote transplant tolerance in humans. And so the way this works is in the bone marrow, we have the hematopoietic stem cell. Now this hematopoietic stem cell, or HSC, can give rise to every blood cell in the body. So your blood cell, your red blood cells, your T cells, everything. And so what we can do in this approach is take a donor hematopoietic stem cell or bone marrow and transplant these cells into a recipient. So these donor HSCs will then migrate into the host or recipient bone marrow and engraft. And so when the immune system comes back in this recipient, you'll have a mix of both donor and host immune cells. Now this will then confer tolerance to donor and host tissues while maintaining the ability to fight off foreign pathogens and foreign tissues. And so this is an approach that has been applied to renal transplantation. Previously, we can get durable acceptance of mismatched kidney transplants for up to 20 years. And this has been work that has been done here at Stanford, as well as other institutions like Columbia. And it's been, proven to work. However, this approach also works in a mouse model as well. We've developed a mouse model to interrogate different aspects of conditioning and hematopoietic chimerism. So we can take a Black 6 host mouse, we can take mice that have a CD45.1 to mark their immune cells. And this can be in the context of diabetes or without diabetes. We can apply a conditioning protocol to these mice and then take donor, completely allogeneic, mismatched BALB-C hematopoietic stem cells and islets and transplant these islets under the kidney capsule and transplant the HSCs. And we can correct diabetes if these mice had diabetes and get mixed chimerism. However, the challenge to applying this approach more broadly to a condition like type 1 diabetes is that in order to undergo hematopoietic cell transplant, you must undergo conditioning. So conditioning creates a space or niche in the host bone marrow for the donor hematopoietic stem cells to come into and engraft, while also temporarily suppressing the host immune system to prevent, just blatant and immediate rejection of these incoming hematopoietic stem cells. And so conventional protocols to condition a recipient for hematopoietic stem cell transplant typically use high doses of radiation or chemotherapeutic drugs, which just induce indiscriminate apoptosis. They can be very toxic, include various side effects like loss of fertility and other, pretty nasty side effects. And so often these myeloablative protocols are used in the case of malignancy, where the risk of the disease is a lot higher than the risk of the conditioning protocol. So it's necessary to perform these regimens on these individuals. However, previously in 2022, our lab, in collaboration with the Suzuru lab here at Stanford, developed a low toxicity targeted protocol, which is based around this anti-c-Kit antibody. So c-Kit is a molecule that is expressed on the hematopoietic stem cell, necessary for HSC survival and proliferation. And so we can get this monoclonal antibody that targets a c-Kit, covering it and preventing c-Kit activity, and we can then deplete the hematopoietic stem cells from the bone marrow niche with this antibody. We combine this with targeted monoclonal antibodies to anti-CD4 and CD8, so to deplete the T cell populations, along with the low dose, a 200 centigrade dose of total body irradiation. And we were able to show that this can provide durable mixed hematopoietic chimerism and can tolerate transplanted islets. And so this is promising move in the right direction. However, even at 200 centigrade, you still have a lot of side effects that come along with that level of total body radiation. And so you can see here, even at the 1 to 350 centigrade range, you still have some pretty nasty side effects, and you increase your chances of secondary malignancies quite a bit. And so according to the Department of Energy, low dose radiation is anything that is 10 centigrade or less. And so for most of us, we're not, physicists, we don't really understand what the different radiation levels mean. I was in that same boat. And so kind of putting that into context, there's a little graph here where you can see kind of the different doses of radiation in comparison to your different daily activities. And so naturally, just walking around in life, you're getting about 0.2 centigrade radiation per year, just doing your normal living. And CT scan is going to be about 1 centigrade dose that you're getting in that scan. So we can lower this down. Can we get this down to about the equivalent of 10 CT scans? And that's about it, which is going to be, no reproducible clinical or biological symptoms at that dose range. And so by getting the total body radiation dose down, we can then kind of tip the balance of, reducing the risk and the benefits. And so we can tip it over to where the benefits of this conditioning regimen are going to outweigh the risk of, the low dose radiation and the other conditioning agents that we use. And so in order to minimize the radiation that we use in order to condition these recipients, we had to look for alternative reagents to help condition the recipient that aren't as toxic. And so work out of Dr. DiPercio's lab at Washington University, kind of spearheaded by Stephen Prasad, they were able to identify a JAK inhibitor, baricitinib, that can enhance generation of mixed hematopoietic chimerism, and it can also be helpful in treating graft versus host disease. So we wanted to see, can we include baricitinib in our conditioning protocol and promote hematopoietic chimerism with reduced radiation? And so that's what we did. We took our normal conditioning protocol, so our anti-C kit, our total body radiation, our T cell depletion with the monoclonal antibodies, and all we did was layer on top daily baricitinib injections from day -5 to day +3 during the conditioning time frame. So we did this in our Black 6 host mice and transplanted our completely allogeneic BALB/C bone marrow. And so when we do this, and we tried 3 different radiation doses of 75 centigrade, 50 centigrade, and 25, we see that we get durable mixed chimerism amongst all of our main immune cell types at 75 centigrade with baricitinib. So we can reduce the total body radiation dose from our previous low of 200 centigrade all the way down to 75 centigrade, so greater than 60% reduction just by adding on this one additional conditioning agent. However, when we get to like the 50-25 centigrade range, we start to see the levels of mixed chimerism drop quite a bit, especially when looking at the T cell populations. We see little to no T cell chimerism with these 2 lower ranges of total body radiation. So we said, okay, adding baricitinib alone, you can get down to 75 centigrade total body radiation. That's still higher than we wanted it to be. So can we add additional agents to further reduce the amount of radiation that we need to get durable mixed chimerism amongst all of our main immune cell lineages? And so the next factor that we looked at was anti-CD47. And so this is work that had been published from Irv Wiseman's group and collaboration with Judy Sejuru, where they showed that anti-CD47 can help to promote durable mixed chimerism in this antibody alone based conditioning. And so CD47 is a don't eat me signal. It's expressed on the hematopoietic stem cell, also expressed on a lot of different cells. And so we can give a monoclonal antibody, block that signaling, and then it'll make those cells susceptible to macrophage engulfment. So we want to see, okay, can we take our normal conditioning protocol, the anti-CD117 c-kit, total body radiation, or T cell depletion? We've added on baricitinib. Now can we add on anti-CD47? And we did this at a higher dose of 300 micrograms per dose in accordance to what they had published in 2019. And when we conditioned the Black 6 recipient mice with this conditioning protocol, we get very good mixed chimerism across the board. Starting as early as 5 weeks, we get very high levels of donor chimerism in most of the main immune cell types, including the T cells. You can see the T cells are up here at 40% starting as early as week 4, whereas they were very low with without the addition of the anti-CD47. The only caveat with this approach, though, is that since CD47 is expressed on so many different cell types, including red blood cells, we see a very large dip in body weight during the conditioning period. So these mice lost up to 20% of their starting body weight, and so it's very toxic on these mice. They had to be treated with supplemental care in order to kind of maintain their body weight and finally start to get them back up. So we want to say, okay, we're trading kind of one poison for another. That's not really the approach that we wanted to take. So can we try to titrate down the anti-CD47 dose and find a dose that is effective while not inducing such wide, negative side effects? And so this work was spearheaded by a very talented undergraduate student in the lab who came in for the summer, and this was a summer project, Diego Burgess. And we wanted to see, okay, can we just do a 7-day conditioning experiment where we start at day -6, condition with different doses of anti-CD47 along with our baricitinib, anti-C kit, and total body radiation. And we can see that when we add, I'll pull up my so here's our untreated control, and we were just looking at live cells per femur, per in the leg that we took out. we can see our control with baricitinib and 100 centigrade, we get nice depletion of total live cells in the femur. And with the 50 and 75 centigrade, we have no significant difference between those two doses. Now, looking specifically at the hematopoietic stem cells, again, we see a significant drop from untreated with our control group. But when we compare just the blue versus the red, we don't see a significant difference between 50 and 75 micrograms per dose of anti-CD47. So we can get down to 50 micrograms per dose of anti-CD47. We get the same amount of depletion. While it's still not enough compared to our positive control, we do get some depletion even at that lower dose of anti-CD47. And more importantly, when we look at the body weight change over time with the 50 microgram per dose of anti-CD47, we do not see that significant dip in the body weight like we do with the higher doses. So we're like, great, okay, we can use anti-CD47, we can titrate it down to a dose that isn't going to cause these wide-ranging negative effects, including this significant weight loss. But we're still not getting the depletion of the hematopoietic stem cell compartment that we need in order to get durable mixed chimerism. So in the literature search, I came across another recent article where they can use a BCL2 inhibitor, venetoclax, and they were able to promote hematopoietic chimerism in non-human primates. And just by adding this BCL2 inhibitor, they were able to reduce their total body radiation dose by half. And so we said, okay, can we then do a similar approach with this venetoclax and see whether we can further reduce the total body radiation? And so we again did a 7-day experiment just to see, okay, venetoclax in different ranges of total body radiation, what kind of depletion are we getting? And so again, we have our untreated control, we have our positive control, baricitinib and 100 centigrade that we know is going to work and clear the bone marrow well. Then we have venetoclax and 3 different doses of total body radiation from 50, 25, and 10. We see just looking at total live cells in the femur, we get a significant reduction in the total cell number in the bone marrow. And similarly, when we look at the 50 to 10 centigrade radiation dose, we don't see any significant difference in just total cell depletion in the femur. Looking specifically at the hematopoietic stem cells, it's a similar story. We get reduction in using venetoclax 50, 25, or 10 centigrade total body radiation. However, we still are not depleting the hematopoietic stem cell compartment to the level that we need to get durable mixed chimerism. So again, we get partial depletion with venetoclax, partial depletion with low dose anti-CD47. Importantly, while we get a small dip in body weight change with the venetoclax, it's only about 5-6%, and it's not as significant as we saw with the high dose anti-CD47 treatment. So we then said, okay, we have, we want to create space in our bone marrow niche, and we want to temporarily suppress the immune system. So we've identified these 3 additional agents that target these 2 objectives. So we got anti-CD47, which is creating niche space, inducing these neutrophil macrophage assisted depletion of the HSCs. We have BCL2 inhibition, which induces apoptosis of these HSCs, as well as apoptosis of peripheral lymphocytes. And we have the JAK1/2 inhibitor in the baricitinib, which is going to attenuate T and NK cell responses and enhance engraftment. So can these 3 additional conditioning agents, which alone and sometimes in combination are pretty non-toxic, enhance the bone marrow chimerism with low dose radiation? So we want to see, can we mix all of these conditioning agents along with 10 centigrade of total body radiation, and do we get durable mixed chimerism after conditioning with this approach? And so again, we condition our black 6 recipient mice. We use our anti-C kit, 10 centigrade total body radiation, our T cell depletion with the monoclonal antibodies, low dose anti-CD47, venetoclax, so the BCL2 inhibitor, and baricitinib. And this is over a 14, 15-day protocol, a conditioning protocol, and then on day 0, we give the donor BALB/c bone marrow. And we find that when we condition these black 6 mice with this protocol, we can see robust mixed chimerism by 4 weeks. It's not, blasting like it was with the high-dose anti-CD47, but most of the immune cell lineages are around that 40% range. The T cells are maintained around 10 or so percent, and this is durable up to 20 weeks. We've taken these out farther as well, and we can see durable mixed chimerism in these mice. Importantly, when we look at the weight change during the conditioning period and then after, we see a small drop in weight during the conditioning period, but this is maintained at like 5% as opposed to that 20% that we were seeing with the high dose anti-CD47. And then once the mice kind of normalize at day 10, they start to gain weight like normal. And more importantly, when we look at the bone marrow of these mice at the end of the experiment after they've been sacrificed, we see that this mixed chimerism isn't only localized to the periphery, it's also in the bone marrow. So we see overall in the B cells, the T cells, myeloid cells, and NK cells of the bone marrow all have robust mixed chimerism. And importantly, the hematopoietic stem cell population in the bone marrow of these recipient mice also have donor chimerism there. So these donor HSCs are actually engrafting into the host bone marrow and helping to give rise to new donor immune cells and maintain that balance of donor and host immune cell populations. So now we want to see, okay, this works in just an allogeneic but non-diabetic setting. Now, can we apply this approach to a diabetic context where you're going to have the added, kind of insults and stresses of high blood sugar and all the inflammatory responses that come along with that? And so we had developed previously a mouse model that allows us to reliably induce diabetes in a black 6 mouse model. So we did this by introducing the RIP-DTR gene in this black 6 mouse that is also on the CD45.1. And so we have the rat insulin promoter driving the diphteriotoxin only in the beta cells. We can then give a single injection of diphteriotoxin and completely ablate the mouse's beta cells. And so depending on the sex of the mice, this takes 3 to 4 days before we start to see declaration of diabetes. But you can see here without diphteriotoxin injection, you have nice islets full of insulin positive beta cells. After diphteriotoxin, we don't have any beta cells that we can see there. And so using this this RIP-DTR mouse model, we can apply this conditioning protocol to these mice. We give diphteriotoxin at day -4 or 3, depending on the sex of the mice. We get diabetes declaration by day -2 to -1, and then we can transplant islets from the BALB/c along with the hematopoietic stem cells or bone marrow from these BALB/c mice, and then see whether we get long-term tolerance of these transplanted islets and diabetes reversal. And so looking just at the mixed chimerism levels in these mice, we can show that even in the diabetic setting, we get robust mixed chimerism that is durable over the 20 weeks that we evaluated in these diabetic mice. So the diabetes does not affect the ability of these mice to become mixed chimeric. And more importantly, looking at the blood glucose range, we see that we give the diphteriotoxin injection, we get severe diabetes up to the 600 non-readable range. However, at day 0, when we give the combined bone marrow islet transplant, the blood glucose levels are normalized, and these maintain up until the point of nephrectomy, where we remove the kidney with the islet graft. So those donor islets are coming out, and we show that those islets were what was controlling the blood glucose. We remove that graft, we get reversion to diabetes. More importantly, we show that this bone marrow transplant, while promoting tolerance of these donor-matched islets, are also able to function normally. So if we transplant non-matched islets, so say islets from an FVB mouse, which is completely unrelated to either the donor BALB/c or the recipient black 6, we still get rejection after the immune system comes back. So we give the diphtherotoxin, we get diabetes, blood glucose is normalized after the combined bone marrow FEB islet transplantation. However, between day 55 to 75, we start to see spontaneous rejection of these FEB islets. So the new reconstituted immune system is functional after it comes back and is able to reject these foreign islet cells. And so kind of we want to look a bit into how is this working? What are kind of the mechanisms? And so in the thymus, you get negative selection to ensure self-tolerance. This is what is going to educate your T cells on what is you and what is not you. And a big proponent of this is also the antigen presenting cells that can migrate into the thymus and show self-antigens to these developing T cells. And so in a normal context, you're going to have host antigen presenting cells or APCs presenting host antigens and deleting host reactive T cells. That's going to be your normal, what's happening in everyday mice, humans, whatever. Alternatively, with the donor, same story. Donor antigen presenting cells presenting donor antigens and deleting reactive donor T cells. However, in the context of mixed chimerism, you can also get a crisscross as well, where you have host antigen presenting cells presenting host antigens to donor T cells and deleting those, and vice versa. So donor APCs presenting donor antigens to host T cells and deleting those donor reactive T cells. And so that is kind of how you're getting this tolerance after mixed chimerism is through this selection in the thymus. And to kind of confirm that, we want to look at, okay, are we seeing these antigen presenting cells or these dendritic cell populations in the thymus of these mixed chimeric mice? And yes, we do see donor chimerism in the thymus in these dendritic cell populations. So our plasmacytoid dendritic cells and our type 1 and type 2 conventional dendritic cells are present in the thymus of these chimeric mice. And so when we look in the thymus at selection of donor-reactive T cells, PD-1 positive thymocytes, it's a marker for negative, like active negative selection in the thymus. And so we can see in just wild type BLAC6 and conditioned BLAC6, we have, kind of 2.5% or so of PD-1 positive thymocytes actively ongoing negative selection. However, that increases significantly when we look at our mixed chimeric mice, indicating that we're getting increased thymic selection in these mixed chimeras, potentially because we're getting the depletion of donor-reactive T cells in the thymus. And so to look at that a little bit closer, mice have this cool kind of system that you can utilize of the superantigens, where you can have a superantigen that will selectively deplete certain V beta chains. So on your T cell receptor, you can have this little component of the T cell receptor called a V beta, and you have different numbers. And so in mice, you have some strains of mice that will selectively deplete, say, V beta 11 in a BALB/C strain, but not in the BLAC6. And so we can take advantage of that. So host BLAC6 mice are going to have T cells with this V beta 11 chain just naturally, while BALB/C, wild type BALB/C mice selectively deplete T cells with this V beta chain on their T cell receptor. And so when we look at V beta 11, we see in the wild type BALB/C, we get significant depletion of these T cells with V beta 11 on their T cell receptor. In BLAC6 and conditioned BLAC6, I just had conditioning alone with no bone marrow transplant. We see high levels of these V beta 11 positive T cells because they're not selectively depleting these T cells. However, in our mixed chimeras, we see depletion, significant depletion compared to the wild type BLAC6 of these V beta 11 positive T cells, indicating that these donor, so BALB/C donor antigen presenting cells are migrating into the thymus and kind of having an influence on the thymic selection of the host T cells in the thymus, which are then depleting these BLAC6 V beta 11 positive T cells. And when we compare this to just a normal V beta 8.1, which is not selectively deleted in either BLAC6 or BALB/C, we see that these aren't depleted in either way. And so now, just to kind of wrap up, we have these barriers to islet transplantation. And so here we have developed a reduced intensity conditioning to achieve durable mixed chimerism across full MHC mismatch. We've shown that here we can get the conditioning radiation down to 10 centigrade. We can get durable mixed chimerism. Once we condition mice with this, we can apply this to a diabetic setting and induce durable tolerance to allogeneic islets without chronic systemic immunosuppression. And so where are we going to go from here? Now we need to address this shortage of pancreatic islet donors. And so our work leading from this is, can we apply this approach to stem cell derived islets? So can we take an allogeneic donor, so this BALB-C donor, can we make mouse embryonic stem cells from it, and then use directed differentiation to generate allogeneic, so BALB-C derived beta-like cells from these BALB-C embryonic stem cells? And then can we condition a diabetic black 6 completely allogeneic mismatched recipient mouse and transplant bone marrow and beta-like cells and get diabetes reversal and islet tolerance of these stem cell derived beta-like cells? And so this will kind of address questions of limited islet donors, and also evaluate whether the kind of immunogenicity of these stem cell derived islets in comparison to primary islets coming from the pancreas. And so with that, I'd like to thank the Kim Lab for all of their help and assistance, our past members, our funding sources, and our collaborators. And I'll take any questions that you might have.
Thanks so much, Stephen. Opening up to questions. I'll have a question while people are sort of formulating theirs. How does the thymic age or the thymic evolution, obviously in adults, I guess it starts around teenage years, right? Affect the ability to retrain tolerance. Have you guys looked at that?
So yeah, that is one limitation of our study. We have done these in young mice, and so yes, you're going to have thymic atrophy. In studies in both humans and mice, if you do it in older mice, the thymus starts to involute pretty young, but common thought is that you then, by the time you get to old age, you have like completely no thymic epithelial cells or thymic function.
Yeah.
However,
So fat.
you do maintain some. So even in older individuals, you're going to have some thymic function. And so even in studies that have done this in older, the reconstitution isn't as great. However, you are going to have some. So yeah, we are going to have to identify, if we are going to apply this to older individuals, methods to kind of enhance thymic function. I know Holger's group is working on kind of studies and approaches to that, as well as, Marcel Vandenberg from City of Hope and stuff. So yeah, those are kind of approaches that they're taking to rejuvenate the thymus and then also kind of mix it with mixed chimerism.
I guess I would also, oh, go ahead. Somebody has a question.
I have a question around the timeline of induction of tolerance. Like, how long does it take for the system to really re-educate itself to be able to then administer an allogeneic cell?
Yeah, so we do them concurrently. So day 0, we do the bone marrow and the islet transplant. I mean, theoretically, we don't see, if we just run a timeline, we don't really see T cells coming back until, like, robustly. We get very few T cells overall at the week 4 time point, and then they really start ramping up around week 8. So I would say you kind of have an 8-week window, at least on the T cell side. You're going to have B cells and your myeloid cells and stuff coming up pretty early. But we've always done it relatively soon. I would imagine you can probably have a week or so peri bone marrow transplant where you can do the allogeneic transplant, but we haven't tested like long term afterwards. Actually, one of my revision experiments is testing that. So where I did the concurrent bone marrow islet transplant at day 0, and then 50 days later do a skin graft. So I'll be able to answer that in a couple of weeks, but yeah.
But do you think you could give the bone marrow first and then come in several months later with the islets, or you think it has to be at the same time?
Oh yeah, no, we've also done those studies too. Yeah, you can give the bone marrow several weeks, even months after the opposite that. You can give the islets several months after the bone marrow. Yeah.
Thanks for that question.
I have a question.
Yes.
So first of all, Dr. Ramos, fantastic presentation.
Thank you.
Very beautiful series of well-designed methodical experiments to reduce the toxicity of the drugs and radiation. So very nice set of experiments.
Thank you.
So congratulations, and on the bioarchive paper. I was going to ask about in recipient NOD mice.
Mhm.
Have you thought about doing similar experiments in NOD recipients?
Yes, and that is a focus. I actually have some slides on that. So that is a focus of a second paper that is in revision right now, where we
Oh,
can do
okay.
this in NOD mice, and we do see so robust chimerism and prevention of diabetes in non-diabetic, so pre-diabetic mice. We can prevent diabetes, and then also in diabetic mice, we can correct diabetes, and we see, most importantly, depletion of autoreactive T cells. So using IGRP tetramer, we can see, diabetic NOD have a lot of these autoreactive T cells. However, in the mixed chimerism, we get depletion of these autoreactive T cells. So this approach does apply to autoimmunity, and you get depletion of those autoreactive cells through the thymic education.
Very nice. The rejection response in the third-party graphs
Mhm.
was fairly slow. Do you think there's some significant immunosuppression, endogenous immunosuppression that is still retained for or the effect of the chimeric immune system is blunted a little bit, because that seems a little bit slower than one would normally get in an FEB to Black 6 combination?
Yeah, so we have seen that in our previous report as well on the 2022 Chang et al., where if you do the FEB islet transplant concurrent with the the bone marrow transplant, so at both at day 0, then it takes about 60 to 75 days for the immune system to ramp back up and actually reject it. If we were to do the bone marrow and then wait, 12 weeks, the T cells have replenished and come back, and then do the FEB transplant, islet transplant, you get rejection of the FEB islets within about 2 weeks. So your normal kinetics. So we're thinking if you do it concurrently, because you are depleting the immune system during the conditioning period, it just takes a while, especially for the T cells, to really ramp back up and kind of come back into circulation.
Yeah, got it. Makes sense. Thanks. Thanks very much. Very nice presentation.
Thank you.
How might this sort of approach compare or even like synergize with other tolerance-inducing strategies like the CAR Tregs or like co-stimulation blockade or like antigen-specific therapies? Like, can you envision any kind of piggybacking or substitution of some of um, some of the tools in your toolkit?
Yeah, I think especially with like the CAR T and CAR Treg could probably synergize. We have done some preliminary studies where we do a so recipient matched Treg infusion peri kind of transplant, and that does help to kind of reduce the amount of radiation that we need. So that can kind of work synergistically. And yeah, there are different ideas to just combine, like I said, thymic regeneration, different tolerance mechanisms. And I think this also just gives, it doesn't have to be like one or the other too. You can
Yeah.
combine them, or this also just gives more options as well. If a patient doesn't want to do, CAR Treg, they can do this. If they don't want to do this, they can do the other. So kind of widens the kind of smorgasbord of options for patients and providers to choose from and find what's going to be best for that individual.
Yeah, that's what I love about your guys' approach is that you're really kind of creating like a toolbox.
Yeah.
And as more inquiry continues, you might be able to add or remove these different drugs, and in that way you're kind of heading towards personalized medicine.
Yeah.
Okay. I guess my last question is, could partial chimerism rather than full be sufficient for tolerance in humans?
Yes, we believe so. So when you get to full, then you start running the risk of graft versus host disease. You start
Mhm.
increasing those chances. And so we found that with partial, it works here. I believe in large animal models, it also works with partial. And studies done with not complete mismatch, but just partial mismatch in humans have shown that even like can transient mixed chimerism can then induce long-term tolerance as well. So it doesn't even have to be, durable through the entire life of the graft. It can just be transient where you get an initial kind of tolerance setting, and then those kind of memory cells are going to be able to hang around and confer long-term tolerance.
Fantastic. Well, this is really exciting times coming out of your work in the Kim lab. I really can't wait to see the next preprint coming from your lab. I think you told us that it's coming soon, so we'll be on the lookout and hope to feature it in our Week in Review newsletter. And thanks again for taking the time to share this.
Great,
Um,
thank you.
and best of luck with everything else. And we'll talk to you again soon. Have a great
Thank you.
rest of your day.
Thanks, everyone.
Bye-bye.